A warm good morning to everybody. Uh, Before we go on to the actual classification of the ocular trauma, a little bit about the epidemiology of this disorder. About 40% of the monocular blindness is related to trauma. It is one of the leading causes of the monocular blindness worldwide. It's said that 70 to 80% of the injured are the males, male being the main bread earner of the society. So it has got ample impact on the on the economic front also. The age can vary from any age from 0 to 100, but the average age being 30 years. That most of the patients of trauma are of younger age group. The incidence of penetrating eye injury is 3.6 per lakh, whereas the incidence of hospitalization is 15.2. So with this burden of the disease, it's imperative for each one of us to know about the management of cases of trauma. Well, broadly we classify ocular trauma according to the causative factor of the injury into two classes. One is a mechanical ocular trauma, another is a non-mechanical ocular trauma. Well, one question arises in our mind, why there is any need for a standardization or the classification of the ocular trauma? It is because without a standardized system, unambiguity exists in properly communicating the globe's condition in cases of ocular injury. The use of standardized term is required in daily practice as much as in publications and presentations. So we have seen, each one of us must have seen some cases being, seen earlier by the ophthalmologist. It's very difficult. Some people write corneal perforation, somebody write corneal penetrating injury, somebody writes corneoscleral perforation with uveal prolapse. So these all things have a different connotations. Therefore, it was needed to have a single terminology so that each time if a word is uttered, it has got a single meaning. Well, the first attempt was taken by this group called the Ocular Trauma Classification Group. This consisted of the committee of 13 ophthalmologists from 7 separate institutes, and they discussed the standardization of ocular trauma classification. This system classified both open globe as well as a closed globe injuries according to the 4 separate variables. The first was a type of injury, and based on the mechanism of injury elicited during the history, or if the history is inconclusive, it may be based on the clinical examination. Next is a grade of injury. The grade of injury, the severity of the injury is defined by the visual acuity in the injured eye at the time of examination. So they divided it into A, B, C, D. A being a visual acuity more than 20/40, B from 20/50 to 20/100, C being 19 to 100 to 5/100, and D being the poorest of all, that is 4/100 to light perception. The third thing they looked upon was a pupillary reflex, and it basically defined whether there was an RAPD or not. So it was defined as a presence or absence of the relative afferent pupillary defect in an injured eye. The fourth one is a zone of injury. Based on the anterior-posterior extent of the injury, the zoning of the trauma is done. For an open globe injury, the zone 1 refers to the injury confined to the cornea and the limbus. Zone 2 involves the anterior 5 mm of the sclera not extending into the retina. And zone 3 involves the full thickness defect where most anterior aspect is at least 5 mm posterior to the limbus. So anything which is 5 mm posterior to anything beyond 5 mm posterior to the limbus will come into zone 3. For perforating injury, the exit site is used to judge the zoning. To determine the zone of injury, many a time a surgical exploration is needed. In cases of closed globe injury, the zoning is done according to the posterior tissue displaying the evidence of structural alteration, and again the zoning being the external, that is limited to the bulbar conjunctiva, sclera and the cornea. The zone 2 is an anterior segment which includes the structures of the anterior segment till pars plicata, and zone 3 is a posterior segment, that is all internal structures posterior to the posterior lens capsule. So now we come to the most important and most valid and most widely used classification system, that is called as Birmingham eye trauma terminology. It was based on a survey conducted at different locations an extensive review of the major trauma-related articles, textbooks, and so they came out with a standardized terminology in what is called as a Birmingham eye trauma terminology. And it has become the most preferred terminology for categorizing the eye injuries in daily and clinical practice. Well, the BETT was designed with 3 criteria in mind. Number 1, there has to be an unambiguous definition for each and every term. The second, the reference tissue must always be determined. And the third, all term must be a part of a comprehensive system which provides an overview so that the ophthalmologist can easily determine in which category an encountered injury belongs. This is precisely how the Birmingham eye trauma terminology exists. An injury is divided basically into closed globe and an open globe. In a closed globe, we can have a contusion or a lamellar laceration, while in an open globe, we can have a laceration or a rupture. Again, a laceration, we can have a penetrating injury or a perforating injury. Another class is that of an intraocular foreign body. Although the intraocular foreign body is technically a penetrating injury, but it has been written separately because of different prognosis and different management. So we'll be defining each and every term which is used in this classification. Open globe injury. Open globe injury basically refers to a full thickness wound of the eye wall. As you can see, this gentleman presented with a history of trauma very commonly seen in our areas with the that hook which is used in their bikes to carry some spring hooks they use for carrying some goods. So this is a typical injury they have at a limbal and corneal junction. The second is a closed globe injury. When there is no full thickness wound, then it is called as a closed globe injury. You can see that there is a huge iridodialysis in this case of trauma. The next term is contusion. Contusion basically refers to a closed globe injury resulting from blunt trauma. The damage may occur at the site of impact or may occur at a distant site from the impact. The third is a lamellar laceration. It is a closed globe injury characterized by a partial thickness wound of the eye wall caused by a sharp object or a blunt object. About the rupture. Rupture basically refers to a full thickness wound of an eyeball caused by an impact of blunt trauma. Since the eye is filled with incompressible liquid, the impact results in momentary increase in the IOP and the eye wall yields at its weakest point. It may be a point elsewhere from the site of impact. As you can see in this case, this was a case of an very old case of an ECCE done, and she had injury with the cattle horn, and the wound gave away at the site of the incision of the ECCE. Now the laceration, this is one of the most commoner form we all encounter in our daily practice. It is a full thickness wound of the eye wall caused by a sharp object. The wound occurs at the impact site by an outside in mechanism as against we discussed earlier rupture. So again we can have a laceration of two types. One is a penetrating or a perforating laceration. A penetrating laceration will have an entrance wound only. There is no exit wound. If suppose there are more than one wound, then each must be caused by a separate agent to qualify it as penetrating injury. For perforating injury, we need to have two sites. One is an entrance wound, another is an exit wound. Again, a retained intraocular foreign body. Technically, it is a penetrating injury, as I have already told you, but they are grouped separately because of the different clinical implication. As you can see, there is a foreign body in the AC, and then again, this is again a very commoner situation we find, that is called extraocular foreign body. Injury with some vegetative material, especially with the paddy and sometimes with the insects, flies and all these things. So they stuck to the cornea, and they are usual foreign bodies commonly in industrial and agricultural worker. Now we have our own very comprehensive classification which is approved by our Trauma Society of the India, and it was proposed by Dr. Shukla et al. The only problem is this is a very comprehensive classification which includes not only the ocular trauma but then associated trauma also. In this also we have a place for Birmingham eye trauma classification. Something about the non-mechanical ocular trauma. The chemical injury refers to both alkali and acid burns. We have a Hughes and Roper-H classification, which classify chemical injury into the 4 grades depending on the state of the cornea and the limbal ischemia. In grade 1 and 2, we have a little or no limbal ischemia and a little bit of corneal haze, whereas in grade 3 and 4, we have a hazy cornea and a limbal ischemia. In grade 3, we have 1/3 to half, and in grade 4, we have more than half limbal ischemia. And as the grades increases, the prognosis becomes poorer. Just to complete the classification system, we can have a thermal injury or a radiation injury. So to summarize the classification system of ocular trauma, we classify ocular trauma according to the type, which is mentioned in the BETT classification. We grade it according to the visual acuity. We should write the pupillary status, whether RAPD is present or not, and finally we should zone the wound so as to have a comprehensive idea about the type of injury. Thank you very much.